Hello everyone, I'm Paul Rumley and I'm a lead partner in the Clinical Agents Department at Royds Withy King. It's sad but true that unfortunately Erb's palsy claims are still a large feature of our clinical agents work as a department. But we are very proud of our long association with the Erb's Palsy Group, which is still the only national charity for people and their families affected by Erb's palsy. And so we thought, who better to talk about Erb's palsy for you all than Karen Hillyer, the chair of the Erb's Palsy Group. And so Karen is going to explain what Erb's palsy is, how it occurs, and how it can be avoided. And then Karen will also go into how Erb's palsy is diagnosed, how it affects people in everyday life, and most importantly, how it can be treated. And so without further ado, it's over to Karen.
What we have is a generation of babies who are slightly heavier, slightly broader, and slightly longer than Mother Nature is anticipating. And this can cause a problem when the babies come to be born and their shoulders are slightly too wide to go through the mother's pubic bones and pelvic bones easily, so they get stuck. Another reason for it can be a positional reason. Sometimes with mothers who are labouring on their back, the baby's shoulders can get stuck due to the position that the mother is in during labour. Once a baby's head has been delivered, the shoulders should follow on the next contraction. This might be the first time a clinician spots that there is a shoulder dystocia, when the baby's shoulders don't follow the head automatically. Once they've identified that this is a potential shoulder dystocia delivery, they should be very prepared with their emergency procedures, which are very simple in the first instance. The McRoberts manoeuvre is very simple. The mother is pulled slightly further down towards the end of the bed. Her knees are flexed and her legs are pushed towards her chest area. This releases the pelvic area and can sometimes result in the baby's shoulders being released automatically. If that doesn't work, it can then be done in conjunction with suprapubic pressure, which is another clinician who has their hand pressing gently against the baby's shoulder through the mother's tummy and just slightly above the pelvic region. This, in conjunction with the McRoberts manoeuvre, is by far the most successful and easiest way to deliver a baby who has a shoulder dystocia. If both of those manoeuvres fail, and you can try them multiple times, there's no limit to how many times you can try those manoeuvres. If those manoeuvres don't result in the delivery of the shoulder, the clinician can then insert a hand into the mother's pelvis and try to free the arm that is not the one that's stuck. It's very easy. The clinician puts the hand inside the pelvis, grasps the baby's arm around the wrist, brings it gently over the baby's head, and that will release the shoulder that's stuck and the baby can be born without injury. Lots of our members report, and it's mostly the dads who have sight of this, and it can be very traumatic for fathers in the delivery room. And what they basically report is seeing the baby's head being pulled and pulled and pulled numerous times by either a midwife or an obstetrician, and it can be quite terrifying. I've had lots of dads say to me, they pulled so hard I thought they were going to pull the baby's head off. And inevitably that much traction is way too much traction, and it's almost inevitable that the child will suffer quite a severe brachial plexus injury. When a baby's first born, it's very apparent if they have an Erb's palsy. The arm that's affected will be very limp, will have no muscle tone, will have no function. If you lift the baby up, the baby's arm will just dangle. When the clinician is doing the APGAR scores, part of the APGAR score is the Morrow reflex, the startle reflex, where they take their hand away from behind the baby's head to startle it, and all limbs should come up. And it's very obvious that the baby's arm will not come up and just hangs very limply by their side. There is absolutely no way you can not see an Erb's palsy in a newborn baby. When they're very tiny, of course, they're not using their arms very much, but as soon as they start to become more mobile at 3 or 4 months, when you expect them to be lying on the floor and playing with both hands, or being able to get to an age where they can hold their own bottle or hold their own knife and fork, it's quite obvious that the baby is unable to do this because they don't have any function in their hand or arm. They're not able to bring their hand to their mouth. So eating is inevitably a one-handed process for them. Crawling can be very difficult for them because they've got an arm that doesn't work, that they get no messages or sensations from to tell the brain to make it work. So the longer it goes on, the harder it is for the child to accept that they have a limb that they get no messages from. So they can fall behind in their natural developmental milestones quite significantly. And this can last throughout life. We have a wide range of people in our organisation who have a spectrum of level of injury, and some of them go from having absolutely no function in their arms at all to some having quite good function. And this can impact on them in a variety of ways, from simple things such as being able to change light bulbs, as being able to learn to drive, being able to change gear in a car. Many of them drive manual cars because, drive automatic cars because they're unable to change gear. And of course, it impacts on their choice of career, because some careers are naturally just not possible for them. Thinking of the armed forces, some types of medicine are not available to people with this injury. Parents have by far the biggest role in treating children with Erb's palsy. From the very start, they have a range of physiotherapy exercises to do on the babies, and these need to be done about 8 times a day. The frequency is very important so that the brain learns that there is some activity in the arm, and then tries to help the neural pathways heal in order to get better function when the nerves recover. From then on, physiotherapy is a daily part of these families' lives, and it will be there until the child is in their teens. There's also occupational therapy if you're lucky enough to have access to it in your area. An occupational therapist will look at ways of aiding the child in terms of righting slopes, how to seat them properly so that the position of their arm is at the optimum place that they can learn. Sometimes occupational therapists will provide splints for children who have muscle contractures that are painful or are resistant to the physiotherapy exercises. Of course, there are surgeries for children with more severe injuries or those who are resistant to physiotherapy and do have muscle contractures. Surgery plays an important part in that. It's a very much a whole team effort, the parents and the therapists and the surgeons together. Lots of parents report struggling, mothers blame themselves, fathers have feelings of anxiety and of having not been useful or helpful to their partner during the delivery. We would urge anybody to seek treatment via their GP initially. Some surgical centres do have access to psychology services there for parents and for anybody who is at the delivery, as well as for those people who actually have the injury as well. They're very aware that it is a traumatic experience, and often they do see signs of PTSD, both in mothers and partners and birthing partners who have experienced the whole situation. Also, our organisation, we're a listening ear. We can help people towards seeking the right sort of treatment and the right services. And we encourage people to talk to each other. Peer support is very important in situations like this. Actually being able to speak to somebody who's been through a similar experience to yourself can be healing. And if we feel that you're not healing the way you should, we would often say to you, seek extra help, seek professional help, and we can help you look for those people to support you through your ordeal. At the time when you are worried about how your baby's going to cope, it's important to realise, yes, it is a devastating injury, but with the right upbringing and a positive outlook, your child can achieve their potential and will achieve their potential. again, what we would say is, let's look at it, let's see how we can help you, and if necessary, signpost you to services which can undertake an investigation for you. But we want to support you. We want you to have the best outcome you can. So get in touch with us.
So that was a very positive call to action there from Karen for parents, birthing partners, and also children affected by Erb's palsy. As Karen says, unfortunately, Erb's palsy can be a significant injury, and also, sadly, it can be, in our experience, associated with subtle brain damage at the time of birth. But the Erb's palsy group are there to support you and your family, and so are we. And so if you would like to discuss any of the issues in respect of Erb's palsy, which Karen has discussed, or any other issues, then we're here and ready to help you, to speak to you on a no cost, no obligation basis. Thank you very much for listening.